My name is Lakshay Khosla, and I'm a visiting subbi from SUNY Downstate. Thank you for the opportunity to present today. Today, I'll be giving a presentation titled Conventional Cystectomy or Non-Surgical Innovations, Fueling the Fight Against High-Risk Non-Muscle Invasive Bladder Cancer. I have no disclosures. To begin, I would like to present a case. A 66-year-old male initially presented with hematuria, dysuria, fatigue, and loss of appetite. He had no weight loss. He has a 20-pack-year smoking history and is a current smoker. On performance status, he can perform most things, activities by himself. He also underwent a physical exam, which showed no CVA tenderness or suprapubic tenderness and a normal cheek exam. When he underwent initial workup, which included a CT urogram and cystoscopy, it showed a bladder mass suggestive of invasion. So he undergoes TURBT, and pathology returns as T1 high-grade disease, but muscle not in specimen. So 6 weeks later, he undergoes repeat TURBT. And this time, the pathology report has muscle in specimen, but not involved, and continues to show T1 high-grade disease. He started on a 6-week induction course of BCG, after which tumor is still seen on surveillance cystoscopy. So he undergoes repeat resection, and it continues to show high-grade disease. He started on a second induction course of BCG that also fails to impact the clinical stage of the tumor. The question becomes, how should we manage this patient? So far in management of this patient, we have followed the guidelines recommended by NCCN after undergoing an initial resection that suggested T1 high-grade disease. He underwent repeat resection to confirm T1 disease. And at this point, the management depends on the risk group for this patient. And in this case, that would be high. So in this presentation, I will give you an overview of high-risk non-muscle invasive bladder cancer, BCG failure and its uses, the guidelines in management, and a review of the treatments that are available for our patient. First, high-risk cancer. Non-muscle invasive bladder cancer, according to a study by the American Cancer Society, is very common in males, Caucasian Americans, and those aged greater than 65. The incidence has increased from 2015 to 2022 from 74,000 to 81,000 cases. And about 75% of these cases are non-muscle invasive. High-risk features are listed on the board over here. Very high-risk features include things such as having lymphovascular invasion, prostatic urethral invasion, being BCG unresponsive, or having variant histologies. And the figure shows to remind us that T1 disease is not invading the muscle, but we start getting concerned because it's approaching that boundary. Next, the uses of BCG and how it may fail. The mechanism of BCG is actually still being researched, and we don't completely know how it may work in treating bladder cancer patients. According to the most recent review by Han et al., what we do know is that BCG enters the bladder cancer membrane through a series of mechanisms and interactions on the cell membrane with proteins, and then once it's inside, it's going to initiate the production of this molecule called NFK-beta. And that initiates an immune cascade, leading to the production of T cells, neutrophils, macrophages that will essentially target and kill bladder cancer cells. The reason we don't know if this is the complete mechanism or what is missing is because this does not fully explain how BCG may work differently in different patients and why it may fail in different ways. So that brings me to how effective BCG may be. According to a meta-analysis of 9 clinical trials, BCG has a 55% complete response rate at 3 years and a 15% progression-free rate. It also has about 20 to 50% of patients who have used it have also had recurrence. And about 5 of those clinical trials were also compared in this meta-analysis. They looked at BCG versus some of the chemotherapies that are available. And they showed that BCG may not be more or less effective overall than these chemotherapies, according to this figure over here. So there are 4 ways BCG may fail, to review them. The first is that the patient can be intolerant to BCG, which means they have severe side effects from BCG. The patient can also be resistant to BCG, which means they have recurrence of lesser disease that can be treated with further BCG. The patient can be relapsing, which means they have delayed recurrence, or the patient can be refractory, which means that they have no complete remission by 6 months after BCG. Our patient would be classified as BCG refractory in this case. Next, a quick overview of the guidelines that are available. Altogether, the AUA, EAU, and NCCN recommend cystectomy for a patient who has BCG unresponsive, high-risk, non-muscle invasive bladder cancer. However, due to recent advances, other therapies have started to make their ways into guidelines as secondary options, such as intravesical therapies. Next, I'm going to review the treatments that are available. Due to some very exciting recent advances, we have a lot of options available, including chemotherapies, immunotherapies, viral and bacterial-based therapies, and enhanced ways of administering the drugs. But before we even get into any of these, let's take a look at the gold standard, which is a cystectomy. There are three primary benefits to getting a cystectomy for this patient. The first is that it will lead to cancer eradication because the 10-year recurrence-free survival rate, according to a retrospective series of greater than 1,000 patients, was 78% for T1 tumors. Secondly, it's also beneficial to patients who may have been understaged in the first place. A retrospective cohort study showed that about 49% of patients have an understaging of their non-muscle invasive bladder cancer. And lastly, there's a greater benefit with earlier resection. If we're planning to eventually get a cystectomy for the patient, it would be more beneficial to do that earlier versus deferred, because another study showed that the 10-year survival rate is about 80% with earlier cystectomy compared to 51 to 61% with deferred cystectomy. But it does not come without its risk, as we all know. A NISPIP database study showed that the 90-day complication rate with cystectomy is about 55%, with 15% being high-grade complications. The figure maps out all the complications that can occur, including things such as infections, bleeding, clotting, and other severe side effects or risks, such as having myocardial infarction or acute renal failure. The mortality rate is less than 3%. So to summarize, these are the pros and cons of getting a cystectomy. The pros, like I stated before, are it will be beneficial to those who have been understaged in the first place. You're treating the cancer, which has a high progression rate. And third, that earlier resection has a greater benefit than deferred resection. And the cons are that there are surgical complications we have to account for. And secondly, it may be used as an overtreatment because we have these alternate therapies that are coming out and available. Thirdly, there's a diminished quality of life associated with cystectomy. And lastly, it's a poor option for elderly with significant comorbidities. So what do? We look at some of the non-surgical options. These have the benefits, number one, that re-resection will be taking note of whether the tumor has progressed. And this sort of counters the point about understaging, because we will be making sure that we have undergone at least 2 resections before going forward with some non-surgical therapy, because that's how we're confirming whether it's T1 high grade or not. Secondly, there's better quality of life if controlled, because you do leave the bladder back in place and there are less side effects associated with the non-surgical options for the most part. That being said, there are cons, because there will be a risk of progression using these non-surgical options because we are leaving that tumor behind. Secondly, there are adverse events that can develop related to the bladder. This is especially important for the intravesical therapy options that are available. And lastly, there's some rare systemic drug events that we have to make sure that we account for. So I'm going to give you an overview of the non-surgical options available, first by comparing some of the chemotherapies and immunotherapies available. In general, the chemotherapies are working to stop the growth of the cell in the cell cycle by interacting on specific mechanisms. But relating to bladder cancer specific therapies, there are 2 main mechanisms, which are the mitotic inhibitors and the antimetabolites. The mitotic inhibitors essentially serve to stop the polymerization or depolymerization of the microtubules during mitosis so that DNA material does not separate properly, and that leads to eventual cell death. Secondly, the antimetabolites, for the most part, are modified nucleotides that are incorporating themselves into the DNA, again, causing DNA damage during replication and synthesis that will be sensed by the cell and trigger cell death. And we have some immunotherapies that work on the mechanism shown on the board over here. Very specifically, they work at the level of this ligand receptor relationship, and PD stands for programmed death. In a normal situation, the tumor cell will present its foreign antigens to the T cell through the MHC complex and TCR receptor interaction. Once that happens, the T cell senses it as a foreign cell, initiates an immune cascade that will lead to the destruction of the tumor cell. However, what ends up happening is some of these tumor cells have this ligand receptor relationship. So when they have that ligand, it will interact with the receptor on the T cell and stop the activation of this entire pathway, and actually essentially protecting the tumor cell against our immune cells. So the immunotherapies are all working to inhibit this interaction over here, either on the ligand side for the tumor cell or on the receptor side of the T cell. That being said, I'm going to compare some of the chemotherapies and immunotherapy options that are available and being researched using two main measures: complete response and disease-free survival. Complete response is defined as the number of patients that are having complete response to the therapies that are being used, and the disease-free survival is defined as the length of time a patient survives without any signs of cancer. First, the FDA-approved options we have available are valrubicin and pembrolizumab. And as seen over here, valrubicin has an 18% CR rate in about 230 patients and a 4% disease-free survival of 2 years, versus pembrolizumab has a 41% CR in 96 patients and an 83% progression-free survival of 1 year. We have some new therapies that are being researched under clinical trials, and some of those chemotherapies are listed over here. Gemcitabine, according to its phase 2 trial data, shows a 50% CR in 30 patients and 21% DFS of 1 year. The dual Taxol regimen, according to its phase 1 trial data, is showing a 22% CR and a 61% treatment failure at 1 year. And the gemcitabine docetaxel regimen is showing a 60% and 46% recurrence-free survival of 1 year and 2 year in 276 patients. And that being said, we also have some new immunotherapies that are emerging. Atezolizumab, according to a phase 2 trial, is showing a 27% CR in 74 patients and a 17% event-free survival of 18 months. And durvalumab, according to its phase 1 trial data, is showing a 46% CR in 28 patients and a greater CR when used with BCG at 1 year. So I presented a bunch of data over here, and let's try to make some sense of it by first looking at some of the CR rates that are available to us. And we can see that amongst the chemotherapies, gemcitabine seems to have the highest CR, and amongst the immunotherapies so far, durvalumab seems to have the highest CR. And secondly, let's look at some of the progression-free, event-free, or disease-free survival rates available. And while these are somewhat different measures, they're measuring the amount of time that a patient can go without having any signs of that type of disease. So amongst the chemotherapy, the highest is seen with gemcitabine and docetaxel, and amongst the immunotherapies, the highest is seen with pembrolizumab. And those are not the only available options. Next, we have some very exciting viral and bacterial-based therapies. Nadofaragene firadenovec is the first FDA-approved viral-based therapy. It's an adenovirus vector that's delivering genetic material to the tumor cell, more specifically an interferon protein, so that the tumor cell can show its foreign antigens and essentially initiate an immune response. According to its trial data, it showed a 53.4% CR in 103 patients and a 24.3% recurrence-free survival of 1 year. And we also have CG0070 in its phase 2 trial. This one is very similar to the first drug, but instead, this adenovirus vector is targeting bladder cancer cells who have a mutated RB tumor suppressor gene. This, according to its phase 2 trial data, showed a 58% CR and a 13% stable disease rate at 6 months. And lastly, TARA-002 is the bacterial-based therapy that's available. It was studied in animal studies, and it's essentially strep pyogenes cells that have been treated with penicillin. And when given to the bladder as a source of treatment, it will initiate an immunogenic response. And it's in phase 1 and currently recruiting, so we're looking forward to seeing the results of this treatment option. Next, we have N803. This is an IL-15 superagonist complex. All that word means is that it's a molecule that's essentially increasing the interaction between BCG immune cells and the bladder cancer cells, which means this is something that's given with BCG, and that mechanism is so much shown over here of it increasing that interaction. According to phase 2 trial data, it's showing a 71% CR and a 57% disease-free survival of 1 year. And lastly, I'm going to talk about ways to enhance the permeability of these drugs. First, we have electromotive drug administration. This makes use of an electric current to increase the permeability of some of the intravesical therapies that are available to us. And we have hyperthermic intravesical therapy. This is making use of heat to increase that permeability of that intravesical therapy option. According to a retrospective series, the data is shown over here. EDMA has a 44% CR in 26 patients and a 58.3% progression-free survival of 1 year. And hyperthermic intravesical therapy has a 70% CR in 56 patients and a 53% recurrence-free survival of 1 year. That being said, we have this patient, it's a 66-year-old male status post 3 TURBTs and 2 induction BCGs, who's presenting with BCG refractory high-risk non-muscle invasive bladder cancer. The question remains, how should we manage this patient? I reviewed a bunch of treatment options that are available to us for management, and to make sense of it, we can look at some of the data ranges that are available, the complete response and event-free survival rates of these different therapies. But that's not the only thing that we have to consider when considering treatment. We have to consider that there's side effects to all these treatment options. Very much generally, the non-surgical options have 2 main side effects you have to consider. One is the bladder irritative symptoms, such as spasms, hematuria, dysuria. And second is fatigue, versus the option of a cystectomy, the surgical option, has 2 main long-term side effects. First is that of infections, and the second is that of problems related to the blockage of urine flow. So decision-making comes down to those 3 things. The first thing is treatment options available. We have to counsel the patients on what the effective treatment options are and what the trial data may be showing. And we have to talk to them about the side effects of these treatments. For example, if a patient has some bothersome LUTs already at baseline, using an intravesical therapy will exacerbate those LUTs. So it may not be the best option for that specific patient. And lastly, we want to talk about patient preferences. Maybe the patient is not preferring to have a cystectomy due to some of the long-term side effects of having it. And while we have other options available, it's something that we can counsel them on and see if that is that is a route that the patient can take in order to ensure shared decision-making. And using all these elements together, we can figure out what the treatment options may be. So with that, I want to ask all those in this room, what treatment option would you pick for our patient and other patients with BCG unresponsive, high-risk, non-muscle invasive bladder cancer? Here are my references. Just thank you to everyone for a great rotation so far and for listening to this presentation. I look forward to working with you for another week.
Congratulations on a great and very comprehensive talk. That was awesome. I think one thing that's really important about BCG is recognizing that in and of itself, it's not just a medical therapy. It has to be combined with good surgery and good decision-making. And when we do a repeat TUR, right? Well, the initial TUR, one of the goals should be complete eradication of papillary tumor, right? So the tumor you see in the bladder, should be able to completely resect it. And then on a repeat TUR, in a previously completely resected specimen, if there's still T1 disease, generally the recommendation is not for BCG, but typically if there's persistent T1, when you think you really TUR'd everything, generally we think of as that person really should proceed to cystectomy based on some really old data, almost 30 years old, looking at persistent T1 disease, showing a really high progression rate if you give them BCG. And so I think sometimes when what we think of as BCG failure can sometimes be failure of actually our decision-making around giving them BCG initially. So just a note of caution that cystectomy can have an early role. Quality of life decline is not always so bad. And I think even elderly patients and even comorbid patients can do really well with cystectomy.
Yeah, no, I absolutely agree with that. But like that being said, I think some of the more recent data is suggesting that cystectomy is impacting like quality of life a lot more compared to some of the non-surgical options. Actually have something available. 1 second. So a study has looked at non-muscle invasive bladder cancer survivors and has shown that there are great impacts on quality of life when compared to bladder preserving treatment options. And it's showing that it's about 4 times as much compared to a radical cystectomy. But that being said, I do completely understand.
Yeah, so I think actually my main point wasn't so much the quality of life, it's actually duration of life. And so if you put someone on BCG who should have had a radical cystectomy early on, right? I'm saying that patient's first induction of BCG, in my opinion, shouldn't have happened. I think they should have had a cystectomy for when there's T1 disease on the second resection. I think a radical cystectomy was indicated at that point. Because of old data showing greater than 80% risk of progression of muscle invasive disease if you treat it with BCG. But obviously there's room for other opinions.
I've always wondered, I mean, I agree. We see a fair number of patients who are referred and their first resection is complete. So that the persistence, I mean, how do you know?
I pretend that the first resection didn't happen. And so if someone had a TUR elsewhere with T1 disease, I redo the TUR, they still have T1 disease. I do a third one as if the first one didn't happen.
That makes sense.
Quick question.
Yes.
Is there any role for neoadjuvant chemotherapy prior to cystectomy, sort of saying the same thing for T1 disease?
That is, I think, something that has been investigated, and according to like the most recent data on that, I think it is beneficial. But if you're eventually going to be proceeding towards cystectomy, I think the general preference is to just go for an earlier one versus a deferred one. You can try neoadjuvant, but there's not any like greater benefit in the long run.
Great talk. So is there any data on subclassification of this disease, and could that have an impact in terms of which treatment this patient should have? So the approach of the personalization of these different agents out there.
Yeah,
What the work is out there right now.
yeah, no, I agree. I think that's another great sort of future direction. I do know in terms of subclassifications, one thing that we worry most about in this disease are the variant histologies. So according to like some of the data available on variant histologies, I think the preference is to go for options such as cystectomy, and this is classified as high risk. But the thing is, even with a cystectomy, we see that there may be overall, cancer-specific survivals that are not as high versus non-variant disease. So I think that's the main sort of place I would see a cystectomy playing a greater role versus not. In other cases, it's under debate whether we would want to go for some of the intravesical therapy options, some of the immunotherapy options, especially since a lot of them are still being studied in their phase trials. And there's just an evolving field, and every sort of month, something new is coming out of it.
I don't know if you're referring to some of the genomic profiling that is now being done, but there is a signal when that testing is done that people with a basal predominant genome phenotype have worse prognosis than a luminal. So there is some, I don't believe that's being used widespread, but the early data with that does look like it can help direct therapy to a certain extent.
Hi, I'm Amanda. I'm really appreciative to be here, and I will be talking today about the effect of obesity on infertility and the potential role of the GLP-1 receptor agonists, what we know as commonly Ozempic, and what they can potentially do. I have no disclosures, so let's begin by acknowledging that infertility is globally on the rise, and there's evidence to show that obese men are disproportionately affected by this. Some of the effects of obesity, which we will define as we will define as a BMI over 30, show a reduction in pregnancy rates, reduced live birth rates despite assisted reproductive technology, or ART, an increased absolute risk of non-viable pregnancies, an increased risk of absolute non-viable pregnancies. Obesity is associated with low semen quality parameters such as semen volume, sperm count and concentration, sperm vitality and morphology, and some specific reproductive hormones such as inhibin and total testosterone and sex-binding hormone globulin. Just an aside, metabolic hypogonadism, which is one of the central causes of infertility in obese men, is associated with increased adiposity. So while I'm aware that BMI is a metric that is falling out of favor per the AMA, if you were to use adiposity index to gauge obesity, it would render these same outcomes. So why does this matter to you? The drugs that will be featured in this talk, such as Ozempic, Wegovy, and other GLP-1 receptor agonists, are increasing in popularity, and it's important to know how they might affect or enhance your clinical practice. Before we discuss an overview in the evaluation of infertility, we need to know the indications for it. Per the AUA guidelines, an evaluation is warranted in couples with failed conception after 1 year of trying, in couples who failed ART trials or recurrent pregnancy losses. Earlier evaluation is warranted if the female partner is over 35 and in patients with an increased risk of sperm parameter abnormalities. So what does that mean? A history of testicular cancer, a cystic fibrosis gene mutation, or someone who's been on chemotherapy. The evaluation itself includes a thorough reproductive history, a physical exam, and semen analyses on 2 separate occasions, 1 month apart, as these are subject to skewing. A follow-up endocrine evaluation is warranted if semen analysis either show low sperm volume or sperm concentration, and those labs consist of an FSH and a total testosterone, with additional labs at the discretion of the clinician, sometimes being an estradiol ratio or a total testosterone to estradiol ratio. All right, before we talk about the values on infertility evaluation in obese patients, and it's important to know, and it's important that we cover normal. So let's review the normal HPG axis. From the hypothalamus, we get GRNH. It's released and stimulates the release of FSH and LH from the anterior pituitary. FSH is released and stimulates Sertoli cells, which lead to spermatogenesis, and LH stimulates Leydig cells producing testosterone. From the gonads, testosterone is converted to DHT via 5-alpha reductase, and testosterone is also converted to estradiol via aromatase. This creates a negative feedback loop where the hormones produced in the cycle exhibit negative feedback at the hypothalamus and the anterior pituitary. While this axis is familiar to you, what I want to talk about What I want to talk about is kisspeptin, which is frankly the linchpin of my presentation. Kisspeptin has receptors in the median eminence of the hypothalamus to stimulate GRNH release, and it also has receptors in the Leydig and Sertoli cells, and it was found to directly regulate both ceratogenesis and spermatogenesis. As we get into the mechanisms of how obesity affects infertility, we need to acknowledge that obesity is accepted as a systemic inflammatory disease. So a high carb diet, we're just going to go through kind of big picture. I think that's always helpful in kind of learning the basics. When we have a high carb diet, there's more glucose and more products of glycolysis, creating more metabolites that need to go through the electron transport chain to be oxidized, thus generating a higher number of reactive oxygen species. These cause macrophages to produce inflammatory cytokines between the adipocytes, and these mediators have two effects that we care about. They increase aromatase, which increases estradiol and decreases testosterone, as well as causing vascular remodeling, leading to reduced blood flow and oxygenation to the testes, generating free radicals, which fragment DNA, resulting in decreased sperm quality and reduced motility. So finally, what are we likely to see when we evaluate infertility in an obese patient? On semen analysis, we can see lower volume or sperm concentration from decreased testosterone or reduced blood flow to the testes, and we'll see decreased sperm quality from increased free radicals in the testes. And on endocrine evaluation, we'd anticipate seeing a low testosterone as a result of increased aromatization, also reflected in increased estrogen and testosterone ratios. As of right now, what's in our medicine cabinet? Clomiphene, which blocks estradiol's negative feedback to the hypothalamus and the pituitary. That's one. You also have anastrozole, which stops the aromatization of testosterone to estradiol, thereby increasing testosterone. And it's important to note that both of these drugs are used off-label. There's also an FSH and an HCG, which replace pituitary function and can be used in those previously on testosterone therapy who have no stimulation from the pituitary. Let's talk about why GLP-1 receptor agonists could be added to this treatment list, potentially. GLP-1 receptor agonists are a class of diabetic drugs which cause insulin secretion in the setting of high glucose, and they slow gastric emptying, causing decreased food intake and leading to weight loss. Liraglutide and semaglutide are GLP-1 receptor agonists that are currently approved for obesity. Liraglutide is a daily sub-Q injection that's titrated to a max dose of 3 milligrams. Patients are reevaluated at 16 weeks because if they're not losing the weight then, it's unlikely that the medication will work later on. Semaglutide is a weekly sub-Q injection that's titrated to a max dose of 2 if it's Ozempic, or 2.4 if it's Wegovy. Wegovy is approved for weight loss and Ozempic is approved for diabetes, and it's recommended that patients take this for life. So how is it that the GLP-1 receptor agonists impact infertility? Through the mechanisms we already discussed, they increase insulin sensitivity, which lower blood glucose, decreasing reactive oxygen species and decreasing inflammatory mediators and aromatase production, which increases testosterone. They cause appetite satiety, causing weight loss, decreasing adipose tissue, decreasing the amount of aromatase able to be produced, and increasing testosterone. They directly stimulate hypothalamic kisspeptin, which they cause leptin surge, which indirectly increases gRNH release, and they directly stimulate hypothalamic kisspeptin, increasing gRNH release. And in the testicles, GLP-1 stimulates testicular GLP-1 receptors, upregulating the affinity kisspeptin has for its receptors in both the Leydig and the Sertoli cells. And in the Leydig cells, activation leads to an increase in testosterone, and in the Sertoli cells, this leads to an activation in spermatogenesis. Lastly, in 2021, it was discovered that there are GLP-1 receptors in sperm, so activation of this receptor increases sperm motility, it's assumed. We got an enhanced understanding of these pathways through several animal studies that serve as hypothesis-generating experiments and basic science theory. After this discovery of GLP-1 receptors in testicular tissue, a study in 2022 out of Egypt examined semaglutide's influence on oxidative stress in the testicles after inducing testicular torsion in rats. So the top image, A, oh, you can't see my cursor, okay, A, on the right, shows the normal histology of the seminiferous tubules. If you move down one, E shows the histology of torsed testicles, which were torsed for 6 hours. We can see the congested and dilated blood vessels, along with atrophied seminiferous tubules populated by necrotic spermatocytes. The bottom picture shows rats' testes who received semaglutide after torsion, and we can see a restoration of the normal architecture of the seminiferous tubules. The study showed an overall decrease in inflammatory markers and cytokines. The results of this study spawned an experiment in 2023, the bottom experiment right here once again. So the top title is for the histological pictures and the bottom title is for the graph that I've included. This experiment looked at whether liraglutide enhanced testicular function through that GLP-1 kisspeptin GRNH pathway in male rats, and diabetic rats who were treated with liraglutide compared to diabetic rats without treatment showed significant upregulation in free testosterone, FSH, and LH. So you'll see free testosterone here on the left, FSH here, and LH here. Diabetic rats are in the middle. And diabetic rats with liraglutide are on your right, and it showed statistical significance in all three comparisons. This enhanced understanding led to our first human study in January of 2023 from the University of Catania, published in the Clinical Journal of Medicine. These are just the preliminary results of this clinical trial, and it was a trial of 110 men ages 18 to 35 with metabolic hypogonadism, which showed that liraglutide treatment improved male reproductive functions as indicated by sperm parameters, serum levels of total testosterone, and gonadotropin levels. The groups were split as follows. So group A were men who were actively seeking fatherhood and were given the standard of care with FSH and HCG for 4 months. Group B were men who were not actively seeking fatherhood and were given liraglutide titrated up to 3 milligrams daily by week 5 for 3 months at that dose. And group C were men who already had conceived and they received transdermal testosterone gel. Of note, it's important to acknowledge that spermatogenesis is a 3-month process, which regulated the time frame for all of the treatments. So let's look at these results. Okay. So compared to at baseline and the other groups at the end of treatment, group B showed significant improvement in conventional sperm parameters. So the sperm concentration increased over 150% and were calculated after treatment at 16 million, which is within normal limits on a semen analysis, being above 15 million. Progressive motility increased by almost 143%, and the mean of 34% again puts that group within normal limits on semen analysis above 32. Group B's total serum testosterone significantly increased by almost 200%, where the total testosterone after treatment was 410 plus or minus 50, which qualified them to be outside of the AUA's range for low testosterone. Remember that number of 300. And the causes for, what I want to say is that the causes for increased total testosterone in this group really could be fourfold. It could just be from weight loss, thus decreasing the aromatase, from increased gonadotropin effects, increased sex-binding hormone globulin, or there's potentially direct activation of this GLP-1 receptor agonist in the Leydig cells to generate testosterone. While promising, the results of this study should be really interpreted with cautions. The reason being that these groups were inherently different at baseline. Group A and Group B have unknown fertility versus Group C that have proven fertility. The ages of these groups aren't reported, and it's possible that Group C is older, having fathered children, versus Group A or Group B, and testosterone levels are age dependent. So this could be could co-found the results. The timing of the testosterone measurements could account for a lower testosterone level in Group A than is actually present. And the total testosterone of Group A was measured 3 to 4 days after the injection of FSH and HCG, but should really be measured 1 to 2 days after the injection, as these are expected to peak within that time frame. Instead, the time at which the testosterone was measured is more representative of a trough. So most importantly, this study fails to highlight whether the improvements in testosterone levels and sperm parameters is either from a direct effect of the GLP-1 receptor agonist on the testicles or due to the weight loss alone. This realization makes us hopeful that these results will be reported in the final trial, but ultimately this could tell us if the medication could be an accessible option for patients with the BMI both over and under 30. Should the final results of the clinical trial be unable to show us the direct effects of this GLP-1 receptor agonist on testicular tissue, it would be prudent of us to conduct a trial with a weight loss control. Another outcome we would wish to see is that if anyone conceived were there birth defects present in the GLP-1 receptor agonist group, similar to those found with other diabetic drugs such as metformin. And so overall, the mechanisms underlying the GLP-1 receptor agonist on reproductive function are likely complex and multifactorial, and further research is needed to fully understand them, but there's a great deal of promise within the field. Okay, thank you to these contributors of this presentation. I really very much appreciate it. And here are my references. Any questions?
I know these drugs have come into the forefront for their weight loss properties, but this is the first I'm hearing about it. Do you think it matters if the sperm counts decrease with cessation of the medication? I know they, for weight loss purposes, you had said that they recommend lifelong use. However, fertility, people don't take Clomid forever. Fertility is kind of a finite event, essentially.
Yeah, I think, and actually discussing this with Dr. Honan and going over the limitations of that study, I think in kind of further thought, you could, if you were to reconstruct another study, something that would be really valuable would be baseline GLP-1 level, and then to get a baseline GLP-1 level in those patients and to see if that level changes at all, and really to see if those parameters do fall, but they increase during the time that you gave it. To answer your question, does it really matter? And I would think no, because these drugs would work for that time of targeted infertility where you're trying to achieve something out of it. I think the goal of weight loss is very different. And so I would, to your point, I would say if they work for infertility for a short time, then why not?
Can you hear me okay?
Yeah.
Yeah, nice presentation. Yeah, there's so many confounding variables with these populations. Is it diabetes? Is it obesity? And is it the mechanism? So, like you said, I think the ideal study would be to look at different methods of weight loss, meaning exercise and diet versus surgical treatment versus this treatment. We didn't really talk about this before, but did you find anything that compared these changes to historical changes in surgical treatment, like gastric bypass or et cetera?
There were, so nothing that compared this directly. I think that would be a very interesting component, but from what I read about the gastric bypass, my understanding is that the results didn't really fluctuate in differences of weight loss types.
Yeah, that's my understanding, that there wasn't a major drop with surgical treatment. So you just wonder if there may be a more direct effect. If this, you got to see if these studies are reproducible.
This is obviously very interesting, and there should be lots more studies. The testosterone study, the one that kind of really dug into, the testosterone level went way up.
Yeah.
For everyone. Did they report that the people felt better? Because the third arm was people taking, androgel, which I'm sure they felt way better. Was that part of it, or is that
wasn't an outcome? And I think that would be a really valuable one as well. And as someone new in kind of sitting, I had the privilege of sitting in on Dr. Walker's clinic, and that was a really big topic of question. And I think your overall feeling after testosterone, I can't speak to that, and I wish they had included that. I think another additional a valuable asset to a study would really be to test the free testosterone, right? Because that's the one that's pulling the weight for the infertility. But I think that's a valuable addition.
Thank you everyone for having me for this rotation. And today I'll be talking about the role of cystectomy in the absence of malignancy. And so my objectives for this talk are going to be to weigh the risks and benefits of cystectomy and of leaving the bladder behind at the time of urinary diversion for non-malignant disease. I'm also going to discuss some surgical techniques that can be used to decrease the morbidity associated with cystectomy with urinary diversion. And lastly, I'm going to review some quality of life implications for urinary diversion with or without cystectomy in patients with quote unquote end stage bladder. I also, before getting started, really wanted to address the term end stage bladder as it is sort of loosely defined, and that is bladders that are no longer functional in their capacity or contractility or cause the patient significant pain and symptoms that are refractory to medical and sometimes surgical treatment. And we'll start with a case. This is a case of a 77-year-old man who is seen with a history of prostate cancer that was Gleason 3+3 and was treated with external beam radiation therapy in 2016. This patient also had mild erectile dysfunction and urolithiasis. And after getting his radiation therapy, he developed recurrent stricture disease, with the most prominent stricture being located at the external urethral sphincter. As a result of the stricture disease, he then developed urinary retention and, as a result, overflow incontinence. In terms of this patient's surgical history, he had a distant bilateral inguinal hernia repair, and he also had a TURP prior to being diagnosed with his prostate cancer. He had lithotripsy for treatment of his stone disease, and he had multiple urethral dilations that failed, with his most recent one being in 2022, where he was dilated to 26 French. And when discussing the patient's goals, he really wanted to avoid going through multiple future surgeries, as he had had multiple urologic procedures in the past. He was also really uncomfortable with the idea of catheterization and self-catheterization and didn't want that to be in his future. And his ultimate goal was improved quality of life, as his incontinence was really impacting his social functioning and something he wanted to focus on. So when discussing some treatment options with this patient, the main branch point was to either leave the lower urinary tract intact or opt for urinary diversion. And when talking about leaving the lower tract intact, the patient was offered urethroplasty, which was across the membranous urethra. But some of the possible consequences of this were also discussed, such as a high likelihood of incontinence due to the stricture location at the external sphincter, which could possibly necessitate the placement of AUS. And because of this patient having a history of radiation, there was also high risk of complication with AUS, including erosion and impaired healing. And so it was also mentioned to this patient that there was a possibility that he could end up with a quote unquote devastated urethra if this intervention failed, and might ultimately require urinary diversion to meet his goals of not leaking. And so when discussing urinary diversion with this patient, the patient was offered a chronic SP tube and then also offered an ileal conduit with or without cystectomy at the time of diversion, and offered an Indiana pouch or another continent diversion. And so in the end, mostly based on his goal of dryness and improved quality of life, this patient ended up opting for an ileal conduit with cystectomy at the time of urinary diversion. And there's an ongoing debate of what to do with the defunctionalized bladder at the time of non-malignant urinary diversion. And this really begs the question of who needs a cystectomy and who doesn't at the time of urinary diversion for non-malignant disease. And so the listed indications on the screen are all recognized as benign conditions that can be managed with major surgical intervention after failed alternative management strategies by the AUA. And one of the most studied and thoroughly described indications for urinary diversion with or without cystectomy is actually in the treatment of interstitial cystitis. And though I'm not going to focus on this as the main point of my talk, I think it's important to talk about the literature briefly. And so for this, there was a review that was done in 2017 by Redmond et al., where they had a cohort of 70 patients where they did a urinary diversion and left the bladder in situ. And within this cohort, almost a quarter of these patients then opted to undergo a secondary cystectomy due to their symptoms continuing after the time of urinary diversion. And the most common reasons for these patients saying they would like to undergo your cystectomy was pyocystis and persistent pain. Additionally, Redmond looked at 26 patients with primary cystectomy and conduit cystectomy at the time of diversion. And of these, 77% of the patients had complete relief of their pain after the cystectomy. And it's notable that all 5 failures were patients that did not have Hunter lesions, as shown on the screen, demonstrated on cystoscopy prior to the procedure, which could demonstrate a predictive value in Hunter lesions within the bladder for pain resolution. And while less common than for interstitial cystitis, urinary diversion and cystectomy has been described in the literature for patients with a history of prostate radiation. And in a Bassett et al. 2017 study, they had a cohort of 100 patients and 83% underwent cystectomy at the time of urinary diversion. And it also, you need to think about how the impact of cystectomy, and that is demonstrated here with a really high complication rate within this cohort, with 36% of their patients experience Clavien 3A or higher complications within 90 days. They also reported a very high mortality rate, which was higher than some other studies, but should be considered in possible risks. And they had a high reoperation rate as well, with 20% reoperation at a median time point of 16.3 months. And the risks of adding cystectomy to urinary diversion include, but aren't limited to, longer operative times, more exposure to anesthesia, increased risk of bleeding and blood transfusion, and also higher complication and wound healing, especially in patients that have undergone radiation exposure in the past. And additionally, while the population that undergoes cystectomy for benign disease tends to be much younger than the population that undergoes cystectomy for malignant reasons, the outcomes are similar, and it shows that the risk doesn't significantly change by indication, even though this is a younger cohort generally. And a study in 2016 by Brown et al. Showed that there is an increased risk of complications with urinary diversion when cystectomy is done at the same time. And this, even though the risks that are demonstrated here are slightly lower, it should be noted that this study was a large nationwide study looking at a database. And so it was powered with over 15,000 patients included. And this was only looking at complications up to the time of discharge, not up to 60 or 90 days like some other studies. And while cystectomy can be a morbid surgery, there can also be major complications that come with leaving the defunctionalized bladder behind at the time of urinary diversion. And some of those common complications include pyocystis, pain and spasm of the bladder when it's left behind, hemorrhage from the bladder, and then additionally secondary neoplastic change, especially for patients who have had radiation to the pelvis. And pyocystis is defined as a collection of purulent debris within the often defunctionalized bladder. And it's one of the most cited reasons for having a cystectomy after a urinary diversion. And the incidence varies greatly in the literature, likely due to the wide variety of different populations in which this is studied, but ranges from 4 to up to 33% for patients with a bladder left in situ. And some important risk factors for the development of pyocystis include a history of Proteus species in the urine, history of pelvic radiation, and severe bladder obstruction, with the last two being especially relevant for the patient that I presented in the case. And in terms of the history of Proteus species, there was a study by Dretler et al. that found that in their cohort, 17% of patients developed pyocystis, and of those, 67% of those patients had a positive Proteus urine culture prior to surgery, regardless of whether that was treated. And one complication that's really important to surgeons and patients is the possibility of developing a secondary malignancy within the bladder after prostate cancer or other pelvic cancers that receive radiation. And the majority of studies demonstrate a slightly increased hazard ratio or risk ratio. And there was a 2022 study that was a very large review published by Lee et al. And this found that there was a increased risk with external beam radiation therapy, as is shown in the yellow line here. And there was also increased risk associated with both a combined therapy of external beam radiation therapy and brachytherapy. And the cumulative incidence was the highest in the external beam radiation group, being about 2%. And when compared to patients that did not receive radiation therapy, the cumulative incidence was about 1.37%. And the Lee et al. Study also demonstrated that there's an external beam radiation therapy is an independent risk factor for the development of a secondary malignancy in the bladder. And they also talked about how newer therapies such as brachytherapy, three-dimensional conformational therapy, and intensity modulated radiation therapy may not increase the risk of secondary malignancy. And one additional possible complication of leaving the bladder in place is the development of pelvic pain and cystitis. And as shown in the data I presented earlier, there's a high rate of continued pain and interstitial cystitis in patients with defunctionalized bladders at the time of diversion. And it's also been shown in the literature that any sort of pelvic surgery puts patients at risk for developing new interstitial cystitis, and this should be taken into account. And then additionally, bladders with a history of radiation exposure are at a high risk for painful complications such as radiation cystitis and hemorrhage and just overall pain as well. And so the long-term functional outcomes and quality of life weigh heavily on any patient that's thinking about cystectomy or urinary diversion. But this is particularly salient in this population of patients that tend to be younger and have longer life expectancies ahead of them. So you really do have to weigh the risks and the benefits here. And one quality of life implication is sexual function. And there's some data in both men and women showing that there's better outcomes that are correlated with genital sparing approaches and nerve sparing and vascular sparing approaches. And general sparing approaches within women led to higher sexual function index scores. And one specific surgical thing that led to poor outcomes was ligation of the umbilical artery. But studies have shown that if you ligate the artery down by the bladder, there's much better outcomes than ligating it higher up at its source. And in men, capsule and nerve sparing techniques have demonstrated improved postoperative sexual function. And in a 2017 review by Hernandez et al., they showed that there was an increased risk ratio for radical cystectomy when compared to both capsule sparing and nerve sparing techniques. And there have been a couple of quality of life studies that have been done in patients undergoing cystectomy and urinary diversion for the management of radiation-induced refractory benign disease. And it's notable that in this study, there was a pretty high 30-day complication rate after surgery that was reported at 65.5%. Yet patients still reported statistically significant improvements of quality of life after cystectomy, which are highlighted on the board, including pain, overall social functioning, overall health, and mental health. And even with the high rate of complications, many patients have found improved quality of life. And this is a study that was a pretty small study, but 85% of these patients reported complications with their urinary diversion and cystectomy, but 100% of these patients said they would like to undergo the procedure again if they were given the chance. And 85% said they would have liked to undergo the procedure sooner in order to have the quality of life that they have after surgery. And so this brings us back to the big question of which patients need a cystectomy and which don't. And you really do have to look at the risks here. So to summarize the risks for cystectomy, in some studies, there have been complications that have been listed up to 73% at 60 days when cystectomy is combined with urinary diversion, and up to 40% in some studies have needed transfusion. And in the study I presented earlier, up to 20% of patients needed reoperation due to some form of complication. Additionally, you have to take into account sexual side effects and how that impacts quality of life. And then when thinking about the defunctionalized bladder, there's a high risk of pyocystis when it's left behind, and up to 80% incidence of radiation cystitis in some populations. Additionally, malignancy is a big concern for some patients, and after external beam radiation therapy, there's an incidence of about 2%. Additionally, there's always the risk of developing a bladder pain syndrome after pelvic surgery, and that should be accounted for as well. And so this brings it down to how we really need individualized patient care, and there is no perfect formula for these patients, but each patient should be looked at with their individual risk factors. And it should be discussed with the patient how cystectomy is a very high risk procedure, but leaving the bladder behind can also cause problems for specific patients. And if a patient has minimal risk factors for leaving the bladder behind, it can be done safely with the option of another cystectomy added in the future. So in summary, there are major risks associated with both options, and shared decision-making should really guide the clinical management and be something that every provider does with their patient when discussing this. Additionally, there are modified surgical techniques that can decrease morbidity, and urinary diversion with or without cystectomy can really improve quality of life for these patients. And these are my references. And I would really like to say thank you to everyone, but Dr. Kim and Dr. Moda-Medinia for organizing this rotation. I've had a great time. It's been a pleasure working with everybody.
Did you come across any information on the complications associated with a secondary cystectomy for folks who say develop recurrent pyositis?
Yeah, there is some data on it. It tends to be similar to it. Well, it depends on their history of radiation exposure, if there's like all sorts of fibrosis around the bladder. So it's the data varies a lot there, but it tends to be similar to like other cystectomy, like general cystectomy data. Patients who don't have urinary.
Because you think it's, you think if they're developing these pelvic abscesses and you were already in the belly before, this would be a pretty broad...
It can be. So for patients who, it's similar to patients who have had other pelvic surgeries, and so it's really patient dependent on the amount of like fibrosis, scar tissue around the bladder, from what I read.
I was going to ask just a quick question about people used to talk about supratrigonal cystectomy.
Yeah.
And the thoughts, for patients with these complicated, now obviously not for, certain patients it would not be appropriate, but I noticed that was not mentioned. What are your thoughts about that?
Yeah, so let's see. So, yeah, so there are some studies, most of them are not very current studies about this and showing better outcomes for supratrigonal, and it definitely can be done and tends to be less morbid in terms of the complications, but you still do have the risk of like secondary malignancy, which a lot of people say if you're going in there, why not take the whole thing out? And you still do have like high risk of like bladder pain syndrome and other things.
Yeah, probably not the most appropriate for that one.
Yeah.
Some of the other ones.
Yeah, but for the other ones, there is some pretty good data that the super trigonal approach can be pretty good for patients.
So, it's gonna say great talk. This is something that we don't talk a lot about, cystectomy for benign reasons. I think in urology, when we think about cystectomy, it's kind of something that we have to do because of the morbidity of the procedure. So it's reserved for those bladder cancer patients who don't have an option, but we've forgotten that we've gotten a lot better at doing cystectomy. So the recovery isn't what it once was. So, you know, I think we should start to talk about cystectomies for benign patients.
Yeah, and a lot of this data doesn't include purely robotic data, and I think that's something to really think about. There isn't a lot of data here for either multiple port or single port surgeries, and that could have a huge impact on lowering complication rate and the morbidity of surgery as well.
Yeah, with robotics and ERS, patients went from spending a week in the ICU to home in 3 or 4 days.
Exactly. Yeah.
I think your point that this is like an individualized decision is so important. I think there are plenty of patients, you know, patients with neurogenic bladders who need a urinary diversion with the additional, from like the additional morbidity of a cystectomy may just be like, just too much.
Thank you.